stent, you bring the ureter out, you take a stitch around the detrusor, so you can include the intravesical portion and stitch it. So you really don't have to sort of go into the pelvis to do or change the position. So that is the biggest advantage. But what is important is avoid opening of the urinary tract, avoid sort of direct contact, and also take the entire specimen in one organ bag. Now, talking of this conservative treatment, what I could think about is distal uretrectomy. Again, if you talk about minimally invasive versus open, do a good job. Robotic, minimally invasive, you can do this distal uretrectomy for a conservative line of treatment, do a Boare flap. But I think the lymph node dissection is important. And also for a conservative treatment in a solitary kidneys, like you do segment resection, there is not much difference between open and minimally invasive. And again, I repeat, what is important is a lymph node dissection. That is extremely important here, and these are the different templates for the lymph node dissection here. Now let us look at the outcome. This is important. So we talked about technique, now we talk about the outcome. Is one better than the other? There was one paper which came from Ghulam Nabi in 2012, and he looked at all observational studies and also sort of open versus minimally invasive. There was one only RCT, lap versus open, and this was way back almost in 2009. The study was very small, just had more than I think 40 or 50 patients there. The outcome was basically there was not much difference, less blood loss, discharge from the hospital was early. I think there was no statistical difference. And what is important is the bladder tumor-free recurrence were almost similar in both the studies. They also have many observational studies from 2002 onwards. What they say is blood loss is less, the hospital is still less. But we know all about it. But we are not interested in that. What is interested is whether it reduces the recurrence and you do a completeness of the surgery. This was 2019, one paper of sort of comparing open, laparoscopic, and robotic, and they had about 161 patients, 137 patients, 124 in all three arms. And what was found that the surgery type was not significantly associated with the cervical outcome. So this was another study. What is important is also this study did not show any increased intravesical recurrence as shown in other studies. This was World Journal of Oncology in 2021, open versus laparoscopic. And what was suggested that there were about 18 articles, nearly more than 6,000 patients. And what they found that the laparoscopic surgery or robotic surgery almost like similar oncological outcomes, even in locally advanced disease, because it's not something non-locally advanced disease. This is robot versus laparoscopy systematic review, and there was no sort of comparison, no sort of a difference in the outcomes itself. Last one, this is a multi-center, multinational propensity score matched analysis. And what it did suggest that almost like 756 sort of propensity score match patients, a total of 2,400 patients. And what was important here, there was a worse bladder cancer-free survival in patients going minimally invasive surgery. So this was one paper, I'll go back to this paper, just presented just about a few months ago, and they found that minimally invasive surgery, I think the chance of bladder recurrence-free survival is high. But we need to find out, is the biology of the disease, is it a technique, or what it is? This is extremely important. And this graph shows bladder cancer recurrence-free survival was poor, and this is almost similar survival. No study has looked into quality of venue. I think if you want to take it from here, I think we have to look at all those techniques, open, lap, robotic. I think we should look at how do you take bladder cuff, lymph node, residual stump, and RCT is long overdue. So to conclude, friends, it's extremely important to have complete nephrectomy with the bladder cuff. It's a rare disease, aggressive disease, whichever technique you use it. There is no difference in the outcome except one study which has shown high bladder cancer recurrence in minimally invasive. Do not miss out on lymph node dissection, and the outcome will be better if you be aggressive. Thank you very much.
We have 3 minutes for discussion.
Thank you, Markan, sir. So one important part that I was thinking that will come is the intravesical mitomycin C after whether you do open lap or robotic immediate installation. What is the data and outcomes? Would you please highlight that? Because bladder cancer-free survival, recurrence-free survival is one of the thing that outcome that you highlighted, but what was the status of the immediate intravesical mitomycin C installation?
Yeah, I think it's a good question. People have done that. Problem is if you're taken a bladder cuff, and if you're not very sure, especially in the techniques where you have just resected ureteric opening, allow it to heal, in those patients you can't give mitomycin. But if you are completely closed with bladder, there are people who are given in perioperative period, but I couldn't see much data on that. whether it's beneficial in terms of reducing the bladder cancer recurrence. Yes, people followed it, but I don't know how many people in the audience follow immediate mitomycin C for upper tract TCC. Majority of them, as I mentioned, are very aggressive disease. Previously, I mean, we sort of, got part in Crow's registry also, Crow's registry. We used to see about 2 or 3 patients, and majority of them were advanced, locally advanced disease. And I don't think that case, I would prefer a systemic adjuvant chemo rather than giving something in the bladder. Anyway, 33% chance that these patients would, 33 times chance that they will develop bladder recurrence. So one perioperative mitomycin would make any difference, I'm not sure.
So during intraoperative approach, also during lab, first attack the artery, or when whatever is there, then go to the ureter and clip the ureter. Because at times what happens if you clip the ureter at the beginning itself, few of the surgeons do clip the ureter at the beginning itself. Hide the ureter, all those things can happen, and the dissection already hydronephrotic kidney, then chance of spillage might be more. Would you please highlight about that?
So basically what you do is that's why you clip the ureteric opening from a cystoscopy below first, and then turn the position, and then do the lab.
If that is not feasible, then intraoperatively, once you do mobilize the colon and everything, and you find the ureter there, and
You
clip
can,
that, and
you
go
can,
there.
you can.
But problem is that hydroureter might continue.
Yeah,
That might
I
be
know, I
at
know,
times, yeah.
I know.
Dr.
Yes,
Very much, yeah.
yeah.
Data on the value of lymph nodal dissection
Yes.
in upper tract is not very strong. You have been actually repeatedly mentioning the importance of doing a complete template dissection. Why do you so tell us? Because there is no real strong data on the...
Understand. Like sort of, we are evolving in terms of what's best adjuvant treatment sort of upper tract TCC. We're extrapolating what
This
you
is
get
the
it from the
last
bladder.
question.
Extrapolating from the bladder itself. And again, I repeat and say, I'm sure all would agree this is an aggressive disease. Patients keep on failing quite heavily. And though there is no sort of a standard guideline saying that, you have to follow that, I think in the real practice, being an aggressive disease, it would help you. And if you don't have any adverse characteristic, perhaps some of the subgroup of patients, you may not give them adjuvant therapy, but at least do a good clearance. Thank you very much.
Thank you, Dr. Kochikar, and thank you, Dr. Pavan Raj Chalise, for chairing this session. With such intense deliberations, I think we need a quick break to recharge our mental faculties. So I have good news that we have a tea coffee break, but I also have a bad news that since we've run 5 minutes into the tea break, so I will be cutting short the tea break by 5 minutes, and I would like you to be back by 11:05 when I resume this session, especially the next speaker, Dr. Srinivas Chilukuri, and my chairpersons, Dr. Kannan and Dr. Satyakam. So please be back. Thank you very much.